So tonight, the ESSO webinar is on methods in clinical cancer research. We will go through clinical research being a pivotal for introducing new drugs and techniques in patients' treatments, and how research can be translated from bench to bedside effectively to improve patient care. And there's a difference between clinical trials designs in surgery and drug development research. So hopefully we should pick on a few of these topics tonight. Our first speaker is, just bear with me a second. Our first speaker is Professor Wim Ceelen. He's going to talk about basics of surgical trial design, and he's going to give us his tips and tricks from the GI surgery perspective. So Wim is graduated as a medical doctor from Belgium, and he obtained a PhD at the Ghent University. He currently is a staff surgeon in the Department of Gastroenterology Surgery at Ghent University Hospital, and was appointed in 2010 as the Professor of Surgical Oncology at the university. He's an investigator with the Flemish Research Foundation and leads on the Laboratory of Experimental Surgery at Ghent University. His clinical interests include surgical oncology of the digestive tract, treatment of peritoneal malignancies, and retroperitoneal sarcoma. His experimental research focuses on tumor physiology and biophysics, functional imaging of cancer, and novel approaches to intraperitoneal drug delivery. He has a keen interest in the application of EBM in the field of surgery, and we're absolutely honored to have him with us this evening. So over to you, Wim.
Well, thank you, Afsana, for the kind introduction. I will now share my screen. No, that's not. Let's see. Okay, can you see my screen?
Yes, we can, Wim.
Okay, so let's get started. So as you know, most of the surgical literature consists of so-called cohort series, but usually it's in the form of chart series or retrospective studies, and then authors try to correct for potential confounders using propensity scores, regression models. But in fact, it has been very well shown during the COVID period that even if you have thousands of patients, it's really impossible to accurately measure causal effects from treatments using non-randomized trials. So we really need randomized designs in order to be able to estimate causal effects of treatments. And the same holds for surgical interventions, but as we all know, and Maria will get into some more details after my lecture, surgical trials are faced with very specific complexities, and the question is how can we tackle that? So there are randomized trials being done in the field of surgery. You see here the evolution of the quantity and the quality over the last, let's say, 10 years. It's from a recent publication in JAMA Surgery, and you see that the number of randomized trials has remained more or less stable over the years, and the quality is quite variable. And what you see on the box plots on the right half of the screen, this is the fragility index. And the fragility index is in fact measured by looking at how many events would be needed to be added or subtracted in order to completely change the conclusion of the result into the opposite. That means, for instance, if you have studied 200 patients and the conclusion is that the treatment works with a p-value of 5%, how many patients would you have to treat less or more in order to alter this decision? And if this number of patients is very small, then this points to a fragile study, which is not really robust. And the key quality indicators for surgical trials are given here, and you see that, for instance, in terms of quality control of interventions, and this is important for complex interventions such as surgery, it's only 4% of these trials where adequate quality control was implemented. For other quality parameters such as registering a priori before the start of the trial, this is quite good. It's 63%, but in fact, this should be 100%. And this is an essential quality parameter, the fact that you register a trial before starting it in a formal database such as clinicaltrials.gov or the European EUDRA-CT database or a similar one. So how to get started with the surgical trial? Of course, you need a hypothesis, and a hypothesis is usually generated by clinical experience or a clinical question that you have. And a nice acronym regarding the desired properties of a hypothesis is FINER. So it should be feasible, of course. You should have enough patients. The intervention should be feasible. It should be interesting. It should be novel. It should be ethical, and it should be relevant for clinical practice. And not all hypotheses are ethical. And for instance, it's not really ethical to design a study trying to answer a question which already has been answered. And this may seem obvious, but I do remember that there were several clinical trials that have demonstrated that in gastric cancer, it's really a disadvantage for the patient if you try to combine it with D2 resection and removing the spleen and the tail of the pancreas. And this does not improve survival, and this increases the complication rate. But lo and behold, several years later, there was another similar, identical randomized trial trying to answer this question, where we already knew from previous trials, multiple previous trials, that this is really harming the patient. Then the next step is to choose a trial phase. You, of course, know the difference between phase 1, 2, and 3. Randomized trials are usually phase 3 trials, but also earlier phase trials, like phase 2 trials, can have a randomized design. And my advice is specifically for larger trials to always involve a statistician or a methodologist to help you with the design of the trial, because a bad design will compromise your trial right from the start. Of course, there's an ethical framework that is really important. It's depending on your geographical location. In the European Union, there is the European Union's Clinical Trials Directive, which has now been just updated. It's different for surgical procedures with a device. And so devices are, in fact, regulated completely differently. And the ideal framework is there relevant. And this will also be mentioned or highlighted by Maria in the next talk. And of course, the basis of all ethical regulation is the Helsinki Declaration and the ICH Good Clinical Practice Framework, which is universal and not linked to geographical location. So specifically for surgical randomized trials, the key challenges are the perceived lack of equipoise. If you organize a trial where a medical treatment or a drug treatment is compared to a surgical treatment, it's sometimes difficult to convince the patient or the participating surgeons that there really is a lack of equipoise. So equipoise means that there's a real existing uncertainty about which treatment is the best. This can also be an issue if you try to organize a trial comparing robotic surgery with open surgery. It will be difficult to convince surgeons who are really experienced in robotic surgery that there is an equipoise, even if it really exists. The same holds for patients. Patients who come to a surgeon because of his or her expertise in robotic surgery will, of course, not really readily accept that they are randomized in a non-robotic surgery arm. The impossibility to mask or to blind patients is often difficult. And then the learning curve effects and the quality, the varying quality of surgical interventions are, of course, major challenges because they result in variability of the treatment and therefore variability of the outcome. essential design aspects are mentioned here. You need to choose a endpoint. The endpoint should be relevant. It should be easily and consistently measurable, and it should be a hard endpoint, preferably. For instance, in cancer trials, you can choose overall survival, you can choose disease-free survival. They both have their pros and cons. Of course, overall survival has the advantage that it can be accurately measured, because you know exactly the day that a patient dies, but disease-free survival is more difficult to determine exactly. In fact, it's impossible, because you do CT scans every 3 months, let's say, and if you see a recurrence after 3 months, you know that it occurred sometime in this 3-month period, but the exact time point is, of course, unknown. Superiority versus non-inferiority designs, that's a choice you have to make. And in fact, non-inferiority designs are required when you test a new device or a new intervention against an accepted gold standard. And for instance, in the early days of laparoscopic surgery for colon cancer, the trials that were organized were non-inferiority designs, because there was at that time a worry or a perceived risk that the use of laparoscopy would result in a higher incidence of local recurrence, let's say. So then a non-inferiority design was used because open surgery was regarded as the gold standard of care. Who to mask and who to blind? Obviously, it's usually impossible to mask the surgeons, but you can sometimes mask the patients. And there have been studies, for instance, comparing open cholecystectomy versus laparoscopic cholecystectomy. You can blind the patients by putting a very large bandage on the abdomen, which makes it impossible to see the scar. This has been done, and interestingly, it showed that there was no difference in outcome between open and laparoscopic cholecystectomy. It's a well-known trial. And of course, it is possible and it's mandatory to at least mask the outcome assessors or the statistician for the treatment arm that the patient was assigned to. And then a very important aspect or methodological point is to calculate the sample size. And this is often neglected, but it's essential. You need several sources of information to be able to calculate the sample size. Of course, there's the power that you want to achieve, and that's the probability that you will detect an effect if it exists. There is the type 1 error risk. This is usually put at 5%. But what is very important and often neglected is that you need a hypothesis about the average treatment effect that you will have if the trial is successful. For instance, my hypothesis is that with the new treatment, I will have a 20% improvement in disease-free survival after 5 years. That's a hypothesis, and that's a hypothesis you need in order to be able to calculate the sample size. So you need this point estimate, but you also need a hypothesis about the precision of this measurement, the variance. If you don't have this variance or the standard deviation around this estimate, it's impossible to calculate the sample size. You need it for the formulas. And how do I know what the variance is? Well, what is often done is either to base this on published literature, or an alternative is to base this on a small pilot trial. And that's what we have done with the local study here, a large phase 3 trial that we are conducting. It's not a cancer trial. It's a trial where we look at the effects of beetroot juice on postoperative ileus. But so in order to be able to calculate the sample size for this large study, we conducted a small pilot randomized trial. And in fact, the only aim of this pilot study was to be able to estimate the variance in the outcome. And this information was then used as the input for the sample size calculation of the larger trial. And of course, you need to involve patients. Patient-reported outcomes are more and more important. There are a number of guidelines available. This is the Delta 2 guideline, which has been published in the BMG a few years ago, and you can have a look at that. There are a number of important guidelines and, that are relevant for calculating a sample size. So here in this table, and I will provide the PDF of the presentation to the organizers, and you can ask them to have it, so you can read it afterwards. But so harking, this means hypothesizing after the results are known. This can be avoided by, of course, registering the study before it starts. This avoids the possibility to alter the endpoint after you have the data, or omitting an endpoint or adding an endpoint. And before this was commonly done, this pre-trial registration, this was really an issue. Selection bias is, of course, avoided by adequate random allocation. Performance bias is avoided by masking the patients and the outcome assessors, and also by quality assurance, and by making sure that in surgical trials there is an adequate quality assurance by, of course, for example, demanding videos of laparoscopic procedures, and to make sure that those who are participating in the trial have an adequate level, technical level. Attrition bias can be avoided by performing an intention to treat analysis. Gender bias is important, and you should always look for gender effects. And if you, for instance, apply for funding for the European Union, there's always an obligation to look at gender effects, whether it's animal research or human research. And this is important. Because we know that effects are often different, mainly in pharmaceutical research, and effects can be different in males versus females. So what are the main challenges during execution of the trial? Well, it's mainly, of course, an administrative burden. You need study personnel. It's impossible for a large trial to do everything yourself. And then recruitment, you always overestimate your recruitment capacity, so it always lags behind, and you have to continuously remind participants to think about the trial and to keep their motivation. You have to organize newsletters, meetings, regular meetings, etc., etc. So what about alternative prospective designs for surgical trials? Because as was mentioned, and this will come back later today in the talk of Maria, there are specific challenges in organizing randomized trials in the field of surgery, but there are alternatives. And I have listed them here. The interrupted time series can be used, cluster randomized trials where the unit of randomization is not a patient, but a group of patients, a so-called cluster. This can be a hospital or a ward or any group of patients. Pragmatic randomized trials, registry-based trials, the so-called trials within cohorts, patient preference designs, such as the Ceelen or the modified Ceelen design, expertise-based trials, where patients are randomized to surgeons having a specific expertise. And then finally, tracker or adaptive trials. And this is in fact increasing the use of alternative designs. And this is a very recent publication in the Annals of Surgery by this month, even in November 2022. And you see that there's really a steep increase of the use of alternative designs. So this is an example of an interrupted time series. You just observe the outcome before starting a specific intervention, and then you observe the outcome after the intervention. And this is an example. It's a observation of the use of or the number of diagnoses of prostate cancer in the US after there was a change in the recommendation regarding screening for prostate cancer. And you can see that before versus after, there is a clear drop in the number of prostate cancer diagnoses. This is another example concerning bariatric surgery in the US, and where you can see that after 2014, there was really an increase in the number of bariatric surgeries after the Affordable Care Act was, and so Obama's Affordable Care Act was implemented in the US. A stepped wedge design is a form of cluster randomization. So the unit of randomization is usually a hospital, and it's sequentially rolled out over all clusters, but the order is at random. So whether you do first ward 1 and then ward 5 and then ward 3, so that's at random, but you do that until all clusters have received the experimental intervention. And this stepped wedge design is mainly used when we are convinced that the novel treatment is beneficial. And a specific example, which is shown here, was the implementation of the WHO checklist before embarking on a surgical procedure. This was done using a stepped wedge design, cluster randomized design. And you can see here that in the course of time, all the wards implemented the WHO checklist. What about pragmatic trials? So pragmatic trials have the advantage that they are easier to perform because you in fact use methods which are in daily clinical practice, and also that they have a higher so-called external validity. External validity means that results that you obtain in the trial will also be replicated in the real world. And this is not often the case in randomized trials. We know very well from the literature that the results that you obtained in the strict controlled environment of a randomized trial is often not replicated in the real world because the patient specifics are different, because the methods are different, etc., etc. And so trials can have a varying level of pragmatism, and there is a scoring system for that, the so-called PRESIS. You can see it here, published in the BMG a few years ago. It's a scoring system ranging from 9 points, which is then not very pragmatic, but more an efficacy trial, to 45 points, which is then the maximum, and that's a very pragmatic study. So those are the differences between explanatory and efficacy or efficiency trials. This is an example of a so-called trial within a cohort design. This is a Dutch study. The protocol that you see here was published in 2020, and this is an ongoing trial. And what they did here is put all the patients who underwent a resection for colon cancer or colorectal cancer stage 2 in a prospective cohort, and then patients provide an informed consent twice at the start of the inclusion of the cohort. And then they do a ctDNA, and then if this shows a certain outcome, then patients have to provide a second informed consent, and then they are randomized either to an experimental arm where the treatment, chemotherapy treatment, is guided by the ctDNA, or a standard of care arm. And so this is an example of the TWIC design, so the trial within cohort design. Ceelen's design is very specific. It's in fact developed in order to avoid reluctance of patients to being randomized. And in fact, what you do here is you randomize patients before they give consent. And then if they are randomized to the standard treatment arm, you don't tell them anything. If they are allocated to the interventional arm, the experimental arm, you tell them, by the way, we randomized you in a trial, and do you agree? This avoids, of course, reluctance of patients to enter in trials, but as you can appreciate, the ethics of this way of doing a trial is controversial, and there are only very few examples in the literature of this design. And this is an example from China. It's a randomized trial of RF ablation versus surgery in the treatment of hepatocellular carcinoma. And this was based on Ceelen's method, as you can read here in the abstract. This is another example published in JAMA Internal Medicine. And it's not really a surgical trial. It's based on a nurse-led multidisciplinary intervention versus usual care. But again, randomization was performed before patients gave consent. And this is a variation. It's a so-called patient preference design. And what you do here is you ask the patient, do you agree to be randomized in a study, or do you prefer a certain treatment. And if they say, I prefer a treatment, then they go in the preference group. And if they prefer a drug, they go in this group. If they prefer surgery, in this group. And so this is according to the wishes of the patient. And then you have the RCT group, where treatment is, of course, allocated randomly according to the study protocol. And then in the end, this is, of course, a very complicated and complex analysis, statistical analysis. But in the end, the results of both the preference group and the RCT group are combined to get the outcome. And this is an example of such a study. It is, as I remember, not in cancer. I don't remember the exact. No, it's a reflux surgery. And so this was, if you're interested to read an example of this kind of study, and this is the reference here, where patient preference was used instead of a formal randomized design, where all patients need to give informed consent and are then randomized. And it has been shown in this study in the field of orthopedics that, in fact, using this partially randomized preference trials do not influence the primary outcome. You see that here in this forest plot. If you compare the randomized design versus the patient preference design, that there is really no influence in the outcome or the estimation of the outcome. Adaptive designs. What's an adaptive design? Well, an adaptive design is in fact a design that is mainly interesting because it allows you to limit the number of patients that you need in order to show a certain effect, and it's based on Bayesian statistics. So it's very complex. It's something where you certainly need a statistician. So it's quite challenging, but in fact, what you do is you continuously update the design of the study based on the outcome that was observed until then. And what you do is you continually change the null hypothesis, you change the design parameters. So it's a very modern design based on Bayesian statistics, and it has a lot of advantages, but it's not that common because it's quite demanding, both in terms of design and in terms of analysis, computational power that you need, etc., etc. This is expertise-based randomized trials, where patients are, so this is the concept, where patients are randomized to specific surgeons based on their expertise. And this is an example. It's in the field of the treatment of colon polyps. It's the so-called Triassic trial. And so patients were randomized to get either ESD, so endoscopic submucosal dissection, versus TAMIS. But those were performed by different surgeons in different hospitals. So this is a nice example of an expertise-based randomized clinical trial. And that's, of course, the solution if you want to compare very specific surgical procedures where it's difficult to expect that a surgeon who is an expert in robotics will participate in a trial where patients are randomized to either robotic surgery or open surgery. So this is a potential solution, the so-called expertise-based randomized trial. So to finish, because it's of course a very broad topic and a broad field, and I've just highlighted a few important elements, but I think it's important that surgeons do research and are main investigators, principal investigators in randomized trials. It is possible, it is feasible, and we see that the number and the quality of trials is increasing. You need, of course, to work in an environment that allows you to do research. It's imperative that we have a good insight into the methodology of clinical trials, and there is training available. For instance, this ESSO EORTC methods in clinical cancer research workshops, but also the ESSO is organizing a number of educational events, both during the Congress and outside the Congress. And of course, you need to include patients and the general public in order to maximize the impact for the society. So to conclude, the quality and the quantity of surgical trials is increasing, but there is major room for further improvement. Alternative trial designs can partly overcome the challenges of surgical randomized trials. And in order to be successful as a clinical trialist, you need to work in a research-minded environment. You need protected time, and you need adequate training in at least the basics of clinical trial design and methodology. So with that, I would like to end, and I give the floor back to the moderator. Thank you.
Thank you so much, Wim. Before you go, because I know you're going to have to leave shortly, may I just ask a question that's been raised from the floor? What are the evidence strengths of different subtypes of randomized control trials?
And the evidence what? The first part?
What are the evidence strengths of the different subtypes of RCTs? Or do they all have the same strength? That's what the question is.
Well, the strength of a trial is, of course, depending on the design and on the sample size. So a sample size can be too small, but it can also be too large. If it's too small, you risk to miss potentially important effects. But if it's too large, you will end up with significant effects, no matter how small the effect. If you randomize 2 times 10,000 patients and you have a new blood pressure drug, then a difference in blood pressure of 0.1 millimeters of mercury will be highly statistically significant, but there will be no clinical significance. And so that's also something to keep in mind, the balance between what is statistically significant and what is clinically relevant.
Would they all still be classed as level 1?
Yes.
Evidence.
Yes, sure. Yeah. All these alternative designs would be classified as level 1. Yeah, because they are all prospective controlled trials which enable you to estimate a causal effect without confounding. Yeah.
Wonderful. And then because we've got a number of younger surgeons here with us tonight, how would you recommend for those people that are interested in research how to get involved and be more proactive? What opportunities do we have?
Well, it depends on where you live. In the UK, I know there's a very active surgical community, young surgical community of collaborating surgeons. There is the ASAC, so within the ESSO, there is the Young Surgeons Collaborative, and they are very eager to collaborate, to start working together. So it all starts with having an idea. Once you have a good idea and a good hypothesis, then the rest is, of course, of secondary importance. But I would advise you to follow a course in basic statistics, clinical trials methodology, and collaborate. And the more you collaborate, the easier it is to convince funders and payers to fund your idea and to fund your trial. Yeah.
Thank you so much, Wim, for tonight's session. We really appreciate your comments. If the audience have any other questions that are directly for Wim, please do email or put it in the chat and we will ask him the questions directly and he will respond to you by email. Thank you so much, Wim. Now we will move on to Mariela Cardoso, who's going to speak about basics of surgical trial design, the tips and tricks from the breast surgery perspective. So Maria is a breast surgeon at the Champalimaud Foundation Breast Unit in Lisbon. And she's the associate teacher at Lisbon, at the Faculty of Medicine. It's an absolute pleasure to have her with us because she's also the board member of the ESSO and specialty editor of the breast. She has special interest in aesthetics results of breast surgery, and we are so honored to have you with us today. Over to you, Maria.
Thank you, Roxana. I'm sorry if you are going to hear some noise because Portugal is playing against Ghana and is a mess outside my office. So every time they score a goal, I hear the sound. So if you hear somebody shouting, it's the guys that are shouting. again because they are looking at the match. Okay, so it's a pleasure to be here. We changed our order because Wim needed to go away, but it's good because we changed presentation. I think we can complement a little bit what we were supposed to present to you. So it's a pleasure to be here. And I'm talking, I'm going to pass very quickly and not focus so much on the type of trials, but trying to explain to the young surgical researchers what they have in terms of validation that they can use in their own research. And I will start mainly by explaining a little bit that we as surgeons has been regarded as the poor parents of research. And this is because surgical research was not considered as to be a very good and complete research. And this happened until almost the end of the 20th century. So surgical research was published as very poor quality research. And this was explained because, as Wim talked about, we have several factors that are implicated in research that are difficult to standardize. So surgery is a complex intervention, is very different from the paradigm of drug treatments, and the evaluation of surgery involves several confounding factors. So this is a problem for us. So standardization is difficult, quality control is difficult, patient accrual is difficult, and funding is very difficult. So usually we have not the pharma industry behind us that will fund our research, and we are really in trouble when we try to have funding. And this is a huge problem for us. We know that surgical research has been improving, but we have still a very different comparison from the medical oncology trials that have huge impact on research, and we have several problems in the managing of research and the inclusion of patients and the type of surgical intervention that we have. I'm now going to pass through several things that have been happening in the research arena, in the health research arena, that I think are almost they are as good for surgical research as they are for medical research. One of them, and I think this is very important because we as surgeons, we need to be aware that there are several tools available. Many of them are online, they are free, and they can help us to direct our research even before we are facing the problem of having something that will help us in the statistical part of our research. And one of them is the Equator Network. And the Equator Network is mainly a gathering of people that were directing all the tools that we have to understand the type of construction that we need, to the type of research that we aim to have, from a simple report of a clinical case to a randomized trial. And this is very important, and it's very intuitive because you can sort of say your research is on humans or are you going to use animals, and then you have a sort of tools that you can use to use as a description, a standard description for the type of research that you are going to have. And this is very important because we are not now still in the moment we simply go and we have a case description or a cohort study and we are simply going to describe it as we feel it's good to have. So we have several tools that help us to go to the standard steps that we need to have to, again, arrive at the end and be able to publish a paper that will be accepted in a publication that we aim to have an impact that is important for us. The equator has, of course, practical tools for every type of trials. So Wim talked a lot about randomized trials because, of course, everyone wants to publish a randomized trial and wants to lead a research about randomized trials. And for that, we have the consort reports for randomized trials with several extensions. So the consort is mainly a report for randomized trials, but we have it for non-pharmacological trials. We have for AI trials, so we have all sorts of consort considerations for publication. Again, inside the randomized trials, we have also the spirit that is the publication of the protocol. Imagine that we are going to publish a protocol of your randomized trial that is not already having results. You have the pairing of the consort, so the reporting of the randomized trial. You have the spirit publication for the protocol. And this is very important. You all probably heard about the PRISMA guidelines for systematic reviews, and you have also the CARE standards for case reports. You have the AGREE for clinical practice guidelines. You have the ARRIVE for animal preclinical studies, and you have now the economic evaluation, the SHEARS evaluation, when you have to, for instance, to evaluate and compare the financial toxicity of an attitude versus another one. And this is very important. You have here, I underline all those that are in relation to surgical studies. And here they explore something that I'm going to talk to you about that is called the ideal collaboration. As you know from the medical oncology trials that are in our main areas, that is surgical oncology, the pair that we have to compare what happens in surgical research and medical oncology research, we have something that came out some years ago that is now called the ideal collaboration, that was developed by Peter McCullough, and it's called also the Balliol collaboration because it was developed in the Oxford College, Balliol College, and it's in fact looking at surgery and trying to develop the same design that happens, for instance, in a drug development, but applying to a surgical procedure. So at the moment that you think about the phase 1 trial, here you are thinking about the surgical technique, the surgical differentiation of protocol that you are going to develop as a proof of concept that is going to happen in very few or 1 or 2 patients, and you are going to compare what happens in this technique, this minor procedure, to compare what you do as standard practice. Then you go to a phase 2, so phase 2A. So you are going to develop and compare this with in a large, so still a small number of patients, but you are going to compare it and see if it is safe. Then you are going to pass to the innovation. So we are going to measure and compare with the other group, that is the standard group. And then you are going to proceed to assessment. So usually that goes for a randomized trial. And then you are going to evaluate the effectiveness of this research in a population-based large evaluation. So this is what happens usually when you are going to explore a surgical new technique, comparator, new whatever, and you are going to use this ideal framework, the ideal collaboration that you are going to apply to your trial. And Wim talked about what is efficacy and effectiveness trials. So efficacy trials are explanatory trials, and they aim at determining if an intervention produced the expected result under ideal circumstances. And Wim talked about that. So when we are designing a randomized controlled trial, we know that this population will be very controlled. That's why it's called controlled, and these controls happens due to several factors. So we are exploring these in a very protective environment. Even we, as surgeons, we tend to bias a little bit the type of patients that we include in these trials. This is more seen in, for instance, in the medical oncology trials, because they are more demanding when we are introducing new drugs, but this happens in any type of research. So we as investigators tend to say, for instance, we are not going to include this patient because he cannot, I think he doesn't have the personality to include in a trial. And this is a bias from our side. If we want to have a population that is very wide, we need not to introduce some of our own bias into selecting the population. This usually doesn't happen in the effectiveness trials, the pragmatic trials, because we are testing this measure in a real world clinical setting. So that's when we open completely the use of the technique. So the endpoints, and we also talked about the endpoints. So we all know the endpoints, and if we talk about surgical oncology, the major endpoints are usually local regional relapse or local regional free survival, disease-free survival, so considering the local and the systemic and overall survival. But then we have many more, like the functional effects, like the quality of surgery, so completeness of resection, morbidity, mortality, and quality of life. So we have much more and many more that we need to assess. So just to show you, when we talked about the consort, so the consort is mainly the type of report that we need to have in a randomized trial, and we have this extension for non-pharmacological trials. And this is very important because, for instance, you are conducting a randomized trial comparing X intervention to Y intervention, and you are using several centers. And one of the problems in surgical trials is to evaluate the way each center performs the intervention you want to evaluate, because you can have differences from surgeon to surgeon, from centers that, for instance, operate like more than 100 cases a year, or centers that operate only 20 cases a year. So this will be very important. And when you are reporting the consort checklist, you need to detail how you included this center and why you included this center in these randomized trials, because this can bias the results you are going to have. And this is very important. So you have a list of characteristics that you need to check and describe when you are reporting the randomized trials by using the consort checklist. Passing to my area, and my area is breast cancer. So we have, breast cancer is always pilots in trials because we have lots of breast cancers. It's not because breast surgeons are better than the others, it's because breast cancers are very frequent, and we started working in teams using the multidisciplinary approach very early in the development of trials. So that's why we have so many trials. It's not because there's a difference between this type of surgery and the other, it's because there's a lot. It's like prostate, you have a lot. So we have quite a timeline in developing trials, and those are some of them. And Here, I show you an example, for instance, between the gap of efficacy and effectiveness in surgery with the example of a randomized controlled trial. And that happens frequently in surgery. And it is something that probably every surgeon, even if it is not a breast surgeon, understood about, is the concept of sentinel lymph node biopsy that started in 1999. And in fact, the randomized trials were only presenting their results in around 2010. So that was when it was established that this was a safe procedure. But in fact, and the non-inferiority was proved. But in 2004, everybody was using this all around the world. So it's the difference between when you need to wait for your results and when you, in your practice, so the effectiveness of surgery is quicker than the efficacy proven of surgery. So, and this is a problem between commas, because it's not a problem, it's a way of putting into clinical practice something that you know it's going to prove that is consistent. But the results, so the outcome that you wanted to have in the trial only came out in 2010. This is again the same. So you have the same, you have another trial that is the Amaros trial. So using not surgery, but radiotherapy in patients that have positive nodes. And we again start using this before we have the results. Again, the modification of attitudes in trials is very important, because sometimes, and Wim talked about some strategies that you can use to modify this, but at the time when, for instance, the CALGB is a trial that was used to try to treat all the patients either with breast conservation radiotherapy and tamoxifen, and prove that this was better than only breast conservation and tamoxifen. But along the trial, because it was clear that the criteria of inclusion were too broad, the criteria were going down. So we started with 4 centimeters and any ER positive tumor. So the type of positivity was not important. And then we got down for 2 centimeters because it was mainly evident that we are not going to obtain any result with this trial if we strict the criteria. And this is happening in the adaptive trials now, but it was not a rule that was happening when the CALGB started many years ago. So that's, again, what Wim talked about, is what we can do when we want to do a research and we understand that possibly using a pure efficacy randomized trial is not going to work, because we are not going to be able to recruit, because when we attain our expected outcome, the technique is already completely around the population. So that's why in surgery, we tend to use retrospective analysis of large data sets, meta-analysis of pooled data, decision modeling for theoretical outcomes, and pragmatic trials for real-life outcomes, incorporating patient-centered outcomes. And that's, again, something that is very difficult, because patient preferences and patient-centered outcomes is, again, a problem. And this is not a problem only for surgery, it's a problem in all trials, because the variation in outcomes is so huge that then it's very difficult to compare outcomes of research if you only use patient-centered outcomes and you don't standardize the type of outcomes you use. And again, you have lots of tools. The problem is we don't use them. We have the COMET initiative, and the COMET initiative applies again to every sort of trial. So the COMET initiative wanted to take a little bit of lessons from what was published and standardize a core outcome measures in effectiveness trials. Because if you try to compare apples with oranges, it's of course not possible to arrive at the end and have a very strong level of evidence. So you need to compare something that is comparable. And in surgery, this also happens. What you can is you go to the Commons Initiative webpage, you arrive there, and you see that you put your keywords like breast cancer, prostate cancer, surgical interventions, and you have a list of what is published regarding the core outcome sets of this particular disease or intervention. And with that, before you design your trial, you go there and you see what you can use to compare this with any other things, because otherwise you are again comparing apples and oranges. You are not arriving at any conclusion. Another thing that I think is more important, and in my area, breast cancer, this is more and more important, is surgical trials are very rarely only surgical trials. They are multimodality trials. So they tend to include several areas that treat breast cancer, because breast cancer is not treated by surgeons. Breast cancer is treated by multidisciplinary teams. So we need to use imaging, pathology, radiotherapy, medical oncology, biomaterials, and evaluation. And all these makes trials very important. Of course, if we look at the trials, even in multimodality trials, when we understand that we have a multimodality trial that we want to evaluate and our outcome sets is overall survival or disease-free survival, if we have too many R1 resections, this is not going to work because surgery is working badly. So it's important to understand for our colleagues that are our partners in multimodality trials that we provide, as they provide, a quality parameter in the intervention that we have in this trial, because otherwise it's not going to work. And this happens, and we need to have this into consideration, because if all the centers are not equally experienced, and we saw that in the consort reporting, so if we have centers that are completely different experience and we don't standardize how they are learning the technique, we are going to have different results. And patient selection will be influentiated, we have bias, and we are not going to obtain the same results. And for instance, the URTC have the CERCare that will have this quality assurance. For example, if we are going to have a trial that will include surgery, radiotherapy, and oncology, we need to have these criteria that are going to be checked in every surgical approach. The same with the pathology, and this is very important. If you have a pathology that doesn't comply with the standard of care that you need to have to evaluate the result of surgery, you are going to have problems. I'm not going to go into much detail into this, but because we are at the end, but these are examples of multimodality trials that we have. For instance, this trial stopped because techniques go very quickly, and sometimes we don't finish trials because something happened in development of techniques and it stopped. But this is an example of a radiotherapy and surgical trial that needs a very close collaboration between both disciplines. And of course, the most important trials uniting surgery and medical oncology are the neoadjuvant trials, because there we can really combine both disciplines. So I'm not going to this because I'm already at the end. So clinical trials are very important. We need valid studies. We need to have very good methodology, and we need to have as Wim said, we need to have ambience that allow us to do research. Okay, we can publish case reports, but to do serious research, you need to have conditions to do it. It's not only time, you need to have conditions. When you are a part of multimodality trials, you need to make your team proud of surgeons. So you need to standardize surgery, because it's very important to include surgery as a quality indicator of the trial. And you only can do this with a team. This is my team. And we need to continue to do this every day of our work. And one of the things that makes me more sad is in this wonderful workshop. This was my last protocol group. All those are medical oncologists. So it's very difficult to have surgeons with very good protocols applying for MCCR. And I saw, as Afsana said, we have so many people attending, and it's a pity that we don't have more surgeons in something that is really, really a life-changing thing for research. So thank you so much. And with this, I stop.
Thank you, Maria. What I'll do is, because of time, I'm going to introduce our next speaker, which is Mariela, and then we'll take the questions at the end because we can have a discussion. So Mariela is going to speak about the challenges for young clinical investigators in oncology, results from the international survey that was conducted by MAG. So Mariela is a breast surgeon from Bulgaria. She's a member of the Education and Training Committee of ESSO and MCCR Alumni 2017. She currently is also on the board member of MCCR Alumni Club. Over to you, Mariela.
Thank you. Thank you very much. Can you hear me? Yeah.
Yes, we can.
Yes, thank you. Well, I just want to give a short introduction also to say, as you said, I'm biased both ways. So everybody who are interested in research, they can follow the ASAC activities of ESSO, which I'm part of, but also I am MCCR in the alumni club. So also I would like to promote the MCCR workshop, because this was one of the most life-changing experiences that I have had in my life. After that, I want to ask everybody who are here to contribute to our survey, and I'm sending the link in the chat now for everyone. So in order to have more responses, then you will see that actually we very much need responses, especially in out of Europe. So please feel free and help us to make this survey even better. Now with this, and the last thing, the MCCR will open applications in December, so keep in mind. Yeah, so with this, I would like to share my screen and tell you what have we done by now and what do we know. So this survey was trying to identify the challenges and hurdles in front of young oncologists, any kind of oncologist. And we conducted it between April and August 2022, and actually this is the first presentation of the results. So you can see here we had 89 participants in total from 26 countries. Most of them were from Europe, the most from Italy, then from Bulgaria, this may be because of me, also from Netherlands, from UK, and then we had also a lot from out of Europe. So you can see here the numbers of participants from Europe. We have quite good presentation. And totally, these are 65 responses. What we had from them. So these are mostly young people in less than 40 years. We have also quite good number of people between 40 and 60, and only one person who was after 60, but hopefully consider himself young investigator. Most of them were female, the respondents, but we had quite good gender balance. And most of them were working in academic teaching hospitals or cancer centers. So it was good in this way. Well, as usual, most of our responders were medical oncologists. This was also because it was spread through MCCR network, but also there are quite a number of surgical oncologists, general surgeons, and even breast surgeons. So one of the questions that we asked is there a clinical trial unit in your country or in your institution? And what it was interesting for me to say that if we see the responses from the country, so if at least one person in a country knows that there is a clinical trial unit in their country, so in 100% of European countries taking part in this survey, there is a clinical trial unit. Well, I doubt this 100% a little bit, and I wonder if people truly understand what is a clinical trial unit and how dedicated is this unit actually to developing clinical trials, but this is the outcome. If we go participant by participant, then only 88% actually say that in their countries they know that there is such thing, they exist a clinical trial unit. And if there is a clinical trial unit in their institution, yes, in almost 70% of responses. Then we go about the facilities that they have in the institution where they work, and almost 70% again says that in their institution there is a biobanking, and biobanking is very helpful for translational research. So it's very good that they have this. Secondly, we asked, do you have electronic medical records? This is a topic very modern now in my country, and now we are in process of establishing this system. It's very useful for research for sure, and still there are countries and people that they don't use electronic medical records, and I'm not sure Bulgaria's borderline situation at the moment. So if people have participated in clinical trials, how many clinical trials are currently ongoing in their institution? And again, almost 70% says yes, that we have more than 10 trials now ongoing in our institution, but also there are people who says there is not a single one trial in their institution. What kind of trials they have been taking part? Most of the people actually have been taking part only in both, actually, in observational and interventional trials. And again, some in none. What was their role in clinical trials? Here, the numbers are bigger because people have marked more than one responses. So you can see that the most of the people, 56 people, this is people, have been participating for sure in patient recruitment. And actually this means that some of the doctors are participating only in this way, like patient recruitment. Then almost equal is analysis of the result, clinical trial administration, and clinical trial design. Here, I've tried to give it another view of the same question, because you see here there are a lot of people answering, giving a lot of answers. So actually, there is one person participating only in results analysis, and most of actually people have participated, as I said, only in patient recruitment. So time and money is quite important, very important issue. Actually, we asked in your practice how you organize your time to perform clinical research. And 50% of people actually respond that they dedicate time for clinical research from their personal time, which they are not paid for. Actually, there are actually people who are paid for. So, but for sure, we have a lot of work to work here. It's very hard to do research on your own, on your free time. Funding resources, you can see here that actually the majority of resources coming from pharma, from industry, and then secondly from national research grants, university grants, and from charity, and 4% of cases had no funding. Actually, I was not surprised to see that Bulgaria is one of the countries from one of our participants, actually 3 of the participants from Bulgaria, say that they don't have any funding for research, but also we have one response from Serbia and one from Italy. And now we will go very far to talk about all the other responses that we get. They're out of Europe, but it's very hard actually to analyze this in one group, because there are people from Canada, from USA, but also from Pakistan, from Panama, from Egypt. So it's very, very colorful group of participants and responses. But what stood out is that all 4 participants from Panama, for example, have no access to conducting clinical trials in their institution. 4 out of 5 participants from Pakistan have never been taking part in the clinical trials, and 1 from Georgia and 1 from Panama. And participants from Brazil, Panama, and Georgia, if participated in a trial, it was only observational. We asked, do they have access to a mentor in their work? And we also have this for Europe. I can say that actually the results are quite similar. It was 20% of the Europeans that they responded that they have no access to mentor at all. Actually, many said yes, they have a mentor in their institution. So here 17% said yes, but he or she is practicing in another country, and 12% responded like yes. But it's from another institution in my country. So I think MCCR workshop and ASAC, and also I'm quite sure, I know that there are workshops not for non-Europeans, but out of Europe. For this, they can really help a lot in this. How they found funding? Here, actually, the percent of people who have found no funding at all for their is bigger. What is interesting for me is that the charity funding is lower. So perhaps it's also for awareness campaign for importance of research. How much we can count on charity, and how can we get money for research from there. So this is it actually, and I would like to thank you very much for your attention. I hope even now you'll be even more motivated to respond to our survey. And I hope this gave a lot of questions for discussion now.
Thank you so much, Mariela. Thank you so much. And Maria, if you could unmute us all so we can start going through some questions. Thank you so much to the audience that have asked the questions. It's fantastic. So let's go with the first one. So the question I've been asked is, could you please offer us publications or a selection of publications where we could study this topic with more detail? And obviously the person's also thanking us for a great presentation. So if we ask you, Maria, first, if you've got any suggestions.
Yeah, but if you go to the Equator Network, you have all the publications there. They are all available. I can, of course, give you a list, but if you go to the site of the Equator Network, you have all the publications there. They are all free, okay? So all these publications from the Ideal Network, from the Equator Network, all the indications that you have. So every guideline that you have there was published in different journals, but all the references are there. You have the DOI there, and it's only to click on the link and you have the publication.
Thank you, Maria. Mariela, if we can ask you the same question as well, please.
Yes, and I would very much like to promote another event which is coming actually not this Saturday, but next Saturday on 3rd of December. The iBreast book have a webinar on how to write a paper. I think I know it's free. It's upon registration. So everybody who are interested in this topic, they can also join their webinar and listen.
That's a really good idea, Mariela. Could you just pop the link into the chat for the audience? Is that okay? Because it will help them. They can just click on it and log in. So I've got another question here. For the low resource settings, who could be the core group of the functional clinical trial unit? Maybe Maria, if we go to you first.
It's a very difficult question. It's a very good question, but it's a very difficult question because even in low resource countries, I think the distribution it's very different from center to center, and that will of course depend. I think research is always dependent on the heads of the hospital units academic that you have, because if you have someone that is completely out of the setting of research, it will be very difficult for you to be able to produce some research on the setting, because there's a mindset that is completely different. So I think you are always dependent on someone. If you are not in the scale, if you are not a top person there, you are always dependent on who is the lead of the group where you are, because it can bring you a lot of force to do something, independent of being a surgeon or a medical oncologist or a radiation oncologist. It depends, okay? It depends. Of course, if you are peer-to-peer, even if you are in a low resource country, and we know that pharma has trials everywhere, it's a good work if you don't have many opportunities, because as I said, neoadjuvant trials are the trials that now are all over in all the areas of surgical oncology. So if you have neoadjuvant trials, you know that the patients will come to surgery eventually. Okay, so usually it's what happens. And if you can pair with them and prove to your medical oncology colleagues that you are a very good asset on the trial, they will go. Of course, they will promote your presence in other trials in some other areas. But I think you are always dependent on your boss.
Thank you so much, Maria. So I think that's a really good point, because if you've got research going on in your centre, you can always connect with people externally across the world really now, because one of the things with COVID is we've had more of a connection, but you could reach out and say, well, I'm interested in this trial, can we join in? And Mariela, for the younger surgeons that want to get involved, do you have any tips for them?
Oh, yes, because in a way, not so much, but in a way, Bulgaria is also low resource, especially for research, and for surgery, it's a nightmare. But what I think is a very good way to start is starting a registries, actually, because this is at least you should start having information from somewhere, and this is very hard for a young surgeon to give you to do real trial, to compare something. It's not happening for an old and experienced professor, so how can happen to us? But maybe starting a registry is some very good prospective registries, because I think that the trials nowadays are very much biased from geography. I don't think in Bulgaria there are people participating in a trial so much comparing to other countries, and not only Bulgaria, and Eastern Europe and out of Europe. So really, this is we don't have information from our country. So let's first start collecting this information, giving these resources, and then after we can start with more sophisticated research.
Can I pop in something, just because you talked about the medical records, electronic medical records, as a very important to be able to conduct trials, and it's of course true. But more than medical records is the capacity of have structured data, because you can have a medical record. It's more practical for you to go with the clinics and have the data from images that are connected to the PACS, whatever. But the problem is the structured data. And you were talking about that when you talk about having a registry, because when you go for a registry, you know that you need to extract data from your electronic patient record to some whatever, a red cap, Excel, whatever, that you're going to have your structured data, because in many countries you have electronic patient registries, but you don't use any of the registries to do nothing. So I think it's this start that you, as you were saying, Mariela, that makes a difference, is to want to do something and start with something, even if it is small.
Mm. Thank you. And I think that leads very nicely on to the next question: how to actually get mentors or people that can help guide you, especially if you are getting into research or you've got an idea, and where can we get that from? So if we go to you, Mariela, first this time.
I'm very experiencing in searching mentors for myself here and there. So yes. Well, I think all these societies actually is very much helpful. I'm not sure, but maybe also Maria was a mentor for ESSO, European School of Oncology, recently. So all these societies have mentorship programs, not all, but many. And it's a good idea to try to contact these people. And yeah, this is one way to find a mentorship. I don't know, actually, for people, if you don't have educated people in your country, it's a big problem. And I have this problem because you also, Wim said, find a statistician, find someone to consult on methodology, but there is no, these people doesn't exist in my country. So how to find them? It's very, very complicated. I don't know, just you
But
should.
Mariela, for you, the other thing you've resourced is the fact that when you go to congresses, you almost go with a list of what you need, and then you usually find someone. And this is quite a useful tip, actually, isn't it, Mariela? Because that's quite a useful way of addressing this.
Yes, of course. You should try to go as much as possible to conferences abroad, to webinars, to contact people, and don't give up if someone is too busy or just don't have time now. Yeah, you should keep on trying. This is the other advice. Wim said also collaboration. Collaboration is very, very good.
And because in the UK, there's a lot of collaborative studies, and we've seen quite a lot of collaborative studies coming out, especially in COVID. So one of the participants has asked, do you think a mentor is necessary? Could a young surgeon start alone? And I think if we go to Maria first for that one, do you always think that there is a need for a mentor, or could you just have an idea of a study and run with it? Over to you, Maria.
You can, of course you can. It depends on, everything depends on your will to doing things. And nowadays you have so many tools that are available, and we know that people are clever, they are educated, and they are capable of getting there. I think what Mariela was saying is sometimes, especially in countries with low resources, low middle income countries, where you have more trouble with dealing with established surgical community. If you have a mentor from other place and you produce some research with this mentor, or he is orienting you, they will accept you more. It will be easier to come with an idea that was supported by someone if you went to either a workshop or a congress, or you stayed in a place for 1 or 2 months to get your idea matured and capable of giving some sort of research, than starting your own. Because unless you have some support inside your institution, if you start alone with no one to support you, it will be very difficult.
That's a really good point, Maria, isn't it? Because you often, when you have those questions or you're unsure on something, you really need somebody like a port of call to sort of call and ask upon. Yeah. And that's similar, Mariela, that you were saying, wasn't it? At the congresses, you normally try to talk to people, get some guidance, and make contacts as well. That somebody you can email, like it's not like phone a friend, but it's email a friend.
Yeah, it's very much helpful, and even now when I have how to say a clinical question even to ask, I have colleagues from abroad that I'm constantly being in touch and asking, but it's really very hard to do alone all those things. And then maybe another thing, a way to go would be just to educate others, not to be alone, to create your own media in which you can exist. It sounds very sad, but it's a way to go.
It's collaboration at the end of the day.
Yeah, I don't think it's sad. I think it's a very, very clever way of tackling people. I think COVID took the proximity from people for 2 years. We start seeing now face-to-face events that for instance, I was talking because ESSO, as Mariela was saying, is open to you can apply even if you are not a medical oncologist. You can apply for a masterclass and be there, and you know all types of mentors and possible people that will help you in a face-to-face way that is really very close. These sort of relations are very important then to create a connection that will allow you to pursue your idea. It's much more difficult if you only have a webinar. So we started with 100 something participants, but I don't even know their faces. So it's also always very difficult.
Yeah, that is so true. And I think you're right, to have that face-to-face contact makes a big difference. And I think congresses are important for that reason, and to have a discussion. I just need to thank the speakers for this evening for a wonderful session. We've gone through, hopefully at the end of this, we've got a better understanding of the different trial designs used in surgery, have some understanding of the challenges of cancer surgery, surgery research, and how to become familiar with some solutions and to the problems. You've obviously met the speakers tonight, so I'm sure the speakers with a great smile will agree if you want to contact them. I have introduced them, and they're wonderful, really wonderful, very helpful, and no question is too much of a problem for them to answer, so do drop them a line. I must say I've had a lot of questions about if there's any accreditation. There's no specific accreditation, however, you may request a certificate of participation by emailing info@essoweb.org, and one of our wonderful colleagues will respond to you with a certificate. I hope you've enjoyed this evening, and please do join again for another webinar. And thank you again to the speakers. Any last words from the speakers as we leave? Goodbye.
Thank you for the wonderful moderation, Asana. It was great. And I think the last word is, don't lose your will to do research, because it's so gratifying in the end. And every little victory, I think if you work in a low resource country, small victories are also enjoyed, and possibly more even than great victories in large resource countries.
Thank you. And Mariela, over to you.
No, I cannot say anything better than this. Thank you so much. Really.
Thank you so much. And Maria, I'll hand over to you to say goodbye.
Great. Thank you everyone again for joining today. And since everybody asked, yes, the video will be available on our website and on ESSO's YouTube. So you can check in either later this week or early next week for the recording there. Okay. Thank you, everyone.
Bye.
Thank you. Have a nice evening.
Bye-bye.
Bye.
Bye.